Okay, we'll get started. So, some things you can't escape as a gastroenterologist, obviously, as Dr. Mountain said, your patients with IBS, but also liver functions as well. So I'm sure we all sit in the room here, we've all got patients who you've got at the back of your mind somewhere with abnormal liver chemistry, abnormal liver function tests of varying degrees, I'm sure. But it's quite a common thing. So I thought quite an important topic for us to discuss today. And so I thought the way we could do that is potentially by doing some liver cases, get some audience participation, some interaction, if that's okay, and go ahead and then talk about some of the aspects of liver function tests, in particular the way I divide things up, potentially some tips for you guys, some rules that I tend to use as well, and then just looking at synthetic function a bit later on as well, and a quick couple of slides at the end before you all fall asleep about investigations and some of the things that I tend to do. So should we just go ahead and have a look at a couple of cases? So these are cases from Middlemore. I'm at Middlemore Hospital, and these are all cases in the last sort of 6 months that we've been seeing. So fairly common things that we see of varying degrees, some exciting, some not so, and certainly varying degrees of liver function abnormality. So here's the first case, a 65-year-old female, no alcohol history in the past there, pretty low BMI, so that rules out a few conditions there for you all as well, complaining of pruritus, fatigue as well, and you can see the liver function tests over here. I've highlighted the abnormal ones in red and also written down the reference ranges as well. So any comments from the floor about maybe the pattern of liver function disturbance that you see there? Yeah, I agree. I think I hear the right answer being yelled out there. So you're looking at the GGT, the ALP, they look a bit more predominantly abnormal than, say, the transaminases there. Obviously, the bilirubin not normal at 63 there as well, so a few issues going on. So I agree with that completely. Yep, so obstructed. So someone just yell out your answers if you want. Any other tests you'd like to do with that level of liver function test? You guys sound like you know it all. That's pretty good. So other bloods to check. So synthetic function. What synthetic function parameters should we check? INR, good. Protein, yep, so the albumin, yep, I think that's a very reasonable suggestion. So what do you think about that, guys? Wow, yeah, I agree. Pretty abnormal, so a bit surprising perhaps. It sounded like a pretty insidious, well, a slow onset there, not too much to check, but this is quite a common presentation. We often pick up people like that, so obviously you're a little bit concerned about this patient. Synthetic function poor, liver function tests abnormal. You're worried about this patient. You might wonder about advanced liver disease and those sorts of things as well, so important to think about that. Other tests you'd like to do? Hepatitis, imaging. All good suggestions. Any causes? Start to think about that. So what we did next is some imaging there. So the ultrasound scans showed splenomegaly, a coarse echo texture. Sounds cirrhotic, doesn't it really? Sounds like you're concerned. The spleen gets big, obviously, because of portal hypertension and backflow of blood from your congested liver. And the coarse echo texture looks, some radiologists will suggest this, some won't, but you know, it suggests cirrhosis and problems going on there as well. The next line's a shear wave elastography. Have you guys heard about that, using that? A few shakes of the head there. So it's a non-invasive marker of basically cirrhosis and advanced liver disease. So we basically look at the liver, we pump through a couple of pulses there, and we see how quickly that reflects back. And obviously if the liver's hard and stiff, it comes back pretty quickly. If it's soft and floppy like it should be, then it takes a lot of time, so you get a lower value. So really that suggests quite a stiff liver, consistent with liver cirrhosis there as well. So I heard some mutterings in the room, so a liver screen, we'll go into that a little bit later on, and in this case I've just cut to the chase really. She's got a positive AMA, so anti-mitochondrial antibody. Her alpha fetoprotein, looking at liver cancer, is negative, and anyway, the ultrasound scan is okay. And this is a lady with likely biliary cholangitis, or PBC, primary biliary cholangitis. Pretty typical story, that pruritus, the age, liver function test, and certainly the AMA being positive. And obviously in the future she'll need follow-up for cirrhosis and the complications of that, including portal hypertension, the chances of HCC, those sorts of things, okay? So a fairly typical case, pretty abnormal liver function test. Let's go on to the next case. So I've negated to put the age here. So this is about a 55-year-old gentleman, heavy alcohol consumption for a few years, stopped 4 weeks ago, and friends and family noticed the gradual onset of jaundice, confusion, lethargy, some sleep-wake reversal as well, so a few concerning things from the history. And on examination, the astute registrar picked up that they were jaundiced, had some spiders, and a small shrunken liver as well to examine. How about those liver function tests? You're concerned? Pretty bad. That bilirubin especially is very concerning there, isn't it? The other ones per se don't look too abnormal, but certainly that bilirubin is of concern, and the history sounds bad, doesn't it, I think, for advanced liver disease. Any comments about this set of liver function tests? Hepatocellular abnormalities, I agree. I think the interesting thing, and we'll go on to that, what was that, sorry? It's a mixed pattern, I'll agree with that as well. And I think the other thing is we're seeing a reversal of the ratio of the AST to the ALT as well. And you can sometimes see that, in particular, it gives you a hint that this may be alcohol, or certainly have an alcohol component there as well. So, other bloods to do? Yep, synthetic function, yep, those sorts of things again. So, INR up again, albumin down a bit as well. So, again, suggesting either malnutrition or advanced liver disease, I think, is the culprits there. We did a liver screen for what it was worth. I think most of the information was there in the history, but the liver screen was negative. The imaging, not surprisingly, suggested cirrhosis as well, with a coarse liver ecotexture seen there. And certainly the pattern of liver function disturbance, we've gone on to that, we've mentioned that AST to ALT reversal. So have a look for that in your patients, especially if you're suspicious about alcohol. And this is a diagnosis of alcoholic hepatitis, okay? The story of drinking up until about 4, 6, 8 weeks ago, stopping often leads to this sort of thing, an inflammatory condition. And we use the Glasgow Alcoholic Hepatitis Score, or the Madry's discriminant function, to work out how sick these patients are and whether they'd benefit for ongoing therapy. And this patient obviously was treated with abstinence, looking out for withdrawal, although they had given up for about 4 weeks or so. Vitamin K, they spent a lot of time in hospital, the mortality's pretty high, and because of that Glasgow Alcoholic Hepatitis Score, which was around about 9 or so when this patient presented, we treated them with prednisone for 4 weeks, and they survived that. I think there's a 50% mortality in certain groups, and they obviously came back to clinic later on for follow-up and had cirrhosis follow-up and work up there as well, okay? Any queries or questions about that one? It's a pretty sick patient, and this is the last case I've got before we crack on to the rest of the talk, but a 23-year-old female, unwell for around about 2 days or so, no history of liver disease or problems in the past there, abdominal pain, jaundice, drowsy, brought in by a mother into the accident emergency centre. Depression was noted in the history there as well. Jaundiced when they presented and were examined, no signs of chronicity or chronic liver disease there. And those are the liver function tests. So, any comments from the floor? Yeah, looks concerning with a predominantly hepatic picture. ALT, AST greater than 1,000 or so. Bilirubin also up. Mixed pattern, I suppose. Well, you know, I think they're predominantly AST, ALT, but everything tends to go up. So you very seldom get complete abnormalities in one aspect of the liver function test and normality in the other. So it's a slightly mixed pattern, but certainly the hepatitic element is significant in this case as well. Other bloods? Oh, you guys are onto it. Perfect. Well done. That's good. So some concerns there, obviously, some major concerns. The INR at 2.3 in a young, fit, healthy person. Certainly rise for concern there. Paracetamol level up. The liver screen, for what it was worth, was negative. The ultrasound scan, not surprisingly, I think the liver was a little bit bright in this case, but otherwise was pretty normal. So paracetamol overdose. I'll show you the normogram. You've all seen that before, certainly, and we put her numbers on there, and she was treated with N-acetylcysteine. And I'll just put up the transplant criteria that we use for her. She didn't need transplant, but certainly we've got some criteria that we use for these very sick patients with paracetamol poisoning, and we see how they get on, and if they meet criteria, we have a very low threshold to involve our liver transplant unit to discuss the case and take it further if necessary. So 3 pretty typical cases of varying degrees there, varying outcomes there. So you will see these sorts of things. Often we see them in the hospital a little more, but certainly there are abnormal liver chemistry cases all over the place. So let's have a bit of a look at the rest of the talk there. So as we've mentioned in some of those cases, We try to divide the liver function tests up and try to make it easy for ourselves by looking at cholestatic derangement of liver function test and hepatic derangement as well. So we look at the ALP, the GGT for cholestasis, and the ALT and the AST for hepatic or transaminases. Looking at the synthetic function, we look at the bilirubin, the albumin, and the INR as well to see what's going on. And quite often we can have, and we certainly do see cases from time to time in the liver clinic where the patient has advanced liver disease. Whatever's happened has settled down, and the only abnormalities we have are in the synthetic function. So it really is very important that we check those, we think about those, and we use those to gauge severity and chronicity of liver disease as well. Unfortunately, we've got to look at some old school stuff. It'll take you back a few years. So we're looking at the hepatic lobule. Just helps us understand what's going on, where the abnormalities are. So a stylized diagram on the left and the histology on the right-hand side. And you'll recall you've got the portal triads at the corner of the lobule there with blood flow going through the sinusoids straight into the central vein there as well. So important to just realise that and realise the pattern of abnormalities that we're seeing with each of these different conditions that we do see. Why do patients have abnormal liver chemistry? Well, I thought I'd have a look at my clinic over about 6 months at Middlemore Hospital as to why patients with abnormal liver chemistries presented to my clinic, and you can see that most of my patients were hepatitis B, but there's a smattering of hep C, other metabolic conditions as well, non-alcoholic fatty liver disease and alcohol. There's a gradual trend in these, I'm sure that you'll be aware of. There are trends in what's going on with epidemiology and etiologies of these sorts of things, such that these will change over time as well. So your liver function tests, we routinely order them. Folk have already alluded to the fact that the AST is not routinely performed now, so if you want to get that piece of information, you have to check that separately, and I think that's just a cost-cutting reason by the laboratory. And again, a small proportion of people do have abnormal liver chemistry, and a significant proportion of these people will actually have fluctuant liver function tests and actually normalise their liver function tests. So I think rather than getting too excited with some mildly abnormal liver chemistry, I think taking a good history, making sure there are no concerns, and then potentially repeating those liver function tests later on, I think is a reasonable strategy unless you've got reasons to be concerned. Looking at the patterns, we've talked about this already with the cases, so we try and break it up. I think most of the cases sort of fall into the mixed category of liver function abnormality, but if we're looking at cholestatic, the ratio of ALT to ALP is less than 2. Hepatic, ALT is generally speaking more prevalent and higher, and obviously you get a higher ratio there as well. Looking at the cholestatic causes, this is by no means exhaustive, but it is a fairly big list of different conditions to think about, and certainly when you're taking a history, reasonable to ask about medications, asking about pain in regards to biliary obstruction there as well, taking a good examination and questions for heart failure, liver congestion, those sorts of things as well. Obviously, pregnancy can cause cholestasis as well, so important to think about that as being an issue there as well. And then, as we mentioned, a case of PBC that we saw initially, pretty insidious itch, pruritus, the right age group. So just casting your net pretty wide, having a bit of a think as to what might be on your differential diagnosis, especially if you see those types of liver function abnormalities. So the ALP, so I've broken them down just quickly, just for a bit of background and extra information there. The ALP is produced in a number of different tissues, but in particular produced in bones and also the placenta. So pregnant folk, ALP sometimes can go up, and obviously in growing children you'll see that abnormality in ALP as well. So I wouldn't get too excited, again, unless there are cues from the history or other problems, and you can do an isoenzyme to break it down as well. Really, if the ALP is abnormal, and the GGT is completely normal, not much history, I think it's pretty unlikely to be coming from the liver as well. And cholestasis really causes a leakage of the ALP into the systemic circulation where it's picked up. The GGT found throughout the body, but is found in liver cells as well. They're not elevated in pregnancy, not elevated in bone disease as well, so it's a bit more useful, I think, as well. The GGT can be induced, such as with the anticonvulsant medications, alcohol as well, in the absence of liver disease. We're going on to hepatocellular, so we talk about the ALP, the GGT, now we're looking at AST, ALT as well. It's a bit difficult to divide it up into timelines and say what's going to cause this at this particular time. Generally speaking, there's overlap between timelines for these sorts of things, but think about these conditions. Viral hepatitis for hepatocellular abnormalities, drugs, herbal remedies, ischemia as well. That's a short term, usually less than a few weeks or so. Chronic, again, hepatitis, viral hepatitis in particular, hepatitis B, hepatitis C, fatty liver disease, alcohol, medications again, really the sort of metabolic causes, autoimmune hepatitis, Wilson's disease, fatty liver, pregnancy, those sorts of things. So these things, you know, they sound exciting, but we don't see them too frequently. I think we'd all sort of sit down and have a smattering of patients in our clinic. So, you know, probably not worthwhile going for a Wilson's screen to begin with. Look at all the common things first. The ALT, it's routinely performed by the laboratory. I'm not going to go into the mechanism too much. Found in many tissues, but really is predominantly found in the liver. Fairly specific for liver disease as well, more sensitive than the AST in regards to chronic viral hepatitis. The AST, those of you who are old enough like me, remember doing ASTs for cardiac investigations and heart attacks and those sorts of things. So it's found in other different cells in the body, including cardiac muscle, skeletal muscle as well. So it's not quite as specific. And it's less sensitive in regards to the ALT, in regards to inflammation, but can be used, particularly in alcohol, in your alcoholic patients, just to have a look and give you an idea of what's going on there. A couple of rules here. Chronic liver disease, they're not usually too elevated, so between about 1.5 and 3 times the upper limit of normal, but in chronic liver disease you can get normal transaminases as well. The ratio, as I've mentioned and gone on about that, is usually less than 1, alcohol greater than 2. And there aren't many things that give you a significant transaminitis greater than 1,000, but these are a couple that I sort of bear in mind when I'm seeing sick folk down in the emergency department. Ischemia, viral hepatitis, hepatitis A, hepatitis B, and drugs including paracetamol, halethane, carbamazepine. It's not an exhaustive list, but these are generally speaking the ones that I look out for, especially if you've got a significant transaminitis. A couple of other points here. The degree of elevation doesn't correlate very well with the histology that you see potentially on liver biopsy. The levels can go very, very high and you can get easy improvement and resolution on subsequent biopsies. The liver has an amazing regenerative capacity as well. When the ALT and the AST do start to fall, it does suggest that the acute insult is gone, but you've got to be quite cautious. As I mentioned to you before, the synthetic function is very important. If you're getting improvement of AST and ALT, but the synthetic function continues to deteriorate, your patient probably is still in a little bit of trouble. Okay, I'll flick through some of the synthetic function tests as well. We've gone through those. Bilirubin from hemoglobin breakdown. I'll flick onto them a little quicker. We've got to look at conjugation as well. So most of the serum bilirubin is unconjugated, gets conjugated in the liver and then excreted later on as well. Prognosis in regards to bilirubin, there's a huge reserve of bilirubin production such that it can go up quite quickly and can come down. So there's not a very good correlation between bilirubin levels and prognosis as well, especially in acute cholestatic disease. But in viral hepatitis, alcoholic hepatitis and PBC, there is some correlation and relation to the degree of injury that you see on biopsy. Albumin made in the liver, important protein, 30 grams synthesized per day as well. The levels are multifactorial, dependent on synthesis, the volume of distribution, and also loss as well. So you've got to think about renal loss, you've got to think about malnutrition, you've got to think about the volume of distribution. Your patient may be overloaded as well. So don't automatically jump to the fact that your patient has advanced liver disease because the albumin is low. Think about your overall patient and make sure that you come up with a sort of balanced view on that sort of thing as well. INR, clotting factors are synthesized in the liver. Again, a number of other causes for why the INR might be elevated. So think about those as well, including warfarin therapy. We've all been caught out by that before, potentially. Again, as I mentioned before, this is important to look at the synthetic function. Chronic liver disease, it often sits at about 2, the INR. In fulminant cases can go up to 10 very, very quickly, and we monitor that very, very closely. Even an INR which is slightly elevated like 1.3 in your paracetamol patient needs to be watched fairly closely. 1 or 2 slides on investigations. That's the liver screen that I do. That's you know, a reasonably exhaustive list of all the different things, but you've got to remember taking a good history, correlating that with your findings, and having a look at the pattern of liver function abnormalities. Very important before you tick off all those boxes on that lab form there as well. And a couple of comments. Some of these have been already duplicated, but think about the imaging, what the best modality of imaging is. We can give you assistance in regards to that. Often an ultrasound scan in a non-obese patient is a good modality there as well. And we've talked a little bit about shear wave elastography and fibroscan, which are our non-invasive measures for advanced liver disease. We're doing less and less liver biopsies now, but we still do them in cases which are slightly dubious or we're not completely sure, so that's something up our sleeve as well. So I hope that's been useful for you. Any questions, please ask.